What are the current issues in treatment of venous thrombosis?
There's a number of very important issues in the treatment of venous thrombosis. One of the big issues is the interpretation of the data from the ATTRACT trial, which is a large NIH-sponsored trial, the largest randomized trial to date. The primary endpoint was not met, which means catheter-directed thrombolysis did not reduce post-thrombotic syndrome overall. However, with the recent analysis of the iliofemoral DVT patients, we have found that numerous secondary endpoints, meaning the severity of the post-thrombotic syndrome, disease-related quality of life, pain, edema, were all significantly reduced by catheter-directed thrombolysis. And I believe that will ensure that patients are treated appropriately who are severely symptomatic with iliofemoral DVT. Another major issue is the proper duration of anticoagulation in patients who have had acute deep venous thrombosis. Traditionally, we've treated patients for 6 months, perhaps a year, for proximal DVT. We now have information that the direct oral anticoagulants administered in low dose, that is rivaroxaban and apixaban, significantly reduce the recurrence rate without increasing the risk of major bleeds. And this changes the equation. If we can treat a patient without a risk of major bleeds and reduce their recurrence rate over time, then we should continue anticoagulation at low dose forever, or at least recheck the patient every 6 months to be sure that they're not having any complications. But indefinitely is the appropriate approach right now.
And what are the key roles of antiplatelet therapy?
Well, antiplatelet therapy is predominantly used on the arterial side of the circulation, and we do know that proper platelet inhibition in the face of diseased arteries and in the face of the use of prosthetics has been beneficial. There's another question of whether we can use combined platelet inhibition, and we do know that combined platelet inhibition in some disease states is beneficial. And then the proper choice of a platelet inhibitor. We know from prior large trials with monotherapy, we know that clopidogrel was shown to be better than aspirin in patients with peripheral arterial disease. Now, whether we can carry that over to combined platelet inhibition when we're treating patients with endovascular therapy hasn't been clarified as yet.
And your opinion, what do you think of science meeting?
Well, the science meeting is a very robust opportunity for a medical professional who's interested in vascular disease to get a wonderful concentrated education, and it addresses all phases of vascular pathology and cutting-edge therapy. So I think it's a wonderful opportunity.
Thank you.